Good afternoon. Thank you to Wonderful Wednesday and the Cardiac Output Multiplex Part 2. And what is best and how do I use it? So for those of you who were with me last week, we talked about cardiac output. We talked about non-invasive and minimally invasive. And today we're going to talk about invasive measures for cardiac output. Now, just as a reminder, non-invasive means I didn't actually cannulate you. Minimally invasive means that I put a cannula, but not in your pulmonary artery. And I guess we would say maximally invasive means that I placed a pulmonary arterial catheter to actually measure cardiac output. So really important to remember that whenever we're talking about cardiac output, we think about two things. We think about, are we directing the patient to a goal? Are we setting up information like MAP of 65, CVP of 12, cardiac output of 4.5. Are we setting up a goal and then making the patient meet it? Or are we actually encouraging the understanding of the patient's hemodynamics, which means a much broader perspective, looking at base deficits, serum bicarb, anion gaps, serum lactate, and really fitting the goal to the patient. So basically, there are two perspectives. The first goal is trying to get patients to an acceptable level of a cardiac output. As far as I'm concerned, that's somewhat false, because whatever cardiac output you learn that is normal, the only normal cardiac output is the one that answers the cellular call for oxygen. So I like hemodynamic optimization. Hemodynamic optimization means that my goal is all about trying to improve your blood flow dynamic and your tissue oxygenation. So in either case, wherever it is you work, you need to actually have a discussion. Are we using goal-directed therapy, driving towards an MAP and a cardiac output? Or are we optimizing hemodynamically, trying to achieve better blood flow? And of course, you can use MAP and cardiac output for this information, but beyond that, you're going to have some indicators of tissue perfusion. And that may give you a broader view. In either case, whichever one you're using, that's going to be important, but know your goal. Now, I just want to remind you that cardiac output is the engine which delivers blood flow and gas. So cardiac output, as we know, is the amount of blood the left ventricle, when we're looking at left ventricular measures. So non-invasive, minimally invasive are left ventricular measures. So we're looking at what the left ventricle is ejecting over time. And that time is heart rate in a minute times the efficiency of the left ventricle, which is the stroke volume. Now, the other cardiac output that we're talking about today is right heart cardiac output. That's measured in the pulmonary artery. And although you'd like for the right heart and left heart to be the same, most commonly they're not. And especially or at least the measures of them are not the same, especially in critical patients. So I just want to remind you, cardiac output is heart rate times stroke volume. Stroke volume really indicates the efficiency of the ventricle, and it correlates to the ejection fraction. Heart rate, everyone can measure. All you have to do is look at your bedside monitor. So I'm much more interested overall in stroke volume, which tells me about ventricular efficiency. But if we want a normal value, we have a test. We're taking the CEN, the PCCN, the CCRN, or our ACMP exam. You have to have a normal for a test. For a test, the normal cardiac output is 4 to 8 liters a minute. Cardiac output divided by body surface area yields cardiac index. Normal cardiac index by a textbook is 2.5 to 4. But the real point is, so when you do goal-directed therapy, you are directing goals towards these normals, which are the textbook normals. And that's really okay. But in the words of some really great hemodynamicists, most importantly, really thinking about Paul Marino, Paul Marek, really look at Michael Pinsky, the greatest hemodynamicist of all time, that in their words, the normal cardiac output is the one that answers the cellular demand for oxygen. So that means the absence of metabolic acidosis equals the efficiency of your cardiac output. So that's really important just for us to consider when we're evaluating patients at the bedside. We're getting all those labs back. We're writing down a bunch of numbers, but you got to put this all together to have a really good view about what's occurring for your patient. So just to remember, by textbook, normal cardiac output 4 to 8, Normal cardiac index, 2.5 to 4 liters per minute to the meter to the fifth power. But remember also stroke volume, 60 to 80 cc's, stroke volume index, 35 to 45 mLs per minute to meter to the fifth power, or mLs per beat to meter to the fifth power. And always remember the major determinant here, which is tissue demand for oxygen. If the tissue is demanding oxygen, you should increase your blood flow. If you don't increase your blood flow, the tissues must steal from the reserve of oxygen, and that is reflected to us in the SVO2. Now, why is that important in this talk about cardiac output? Because it's a major factor in the measurement of cardiac output and in the evaluation of cardiac efficiency and hemodynamic optimization. So really, when you're a first-year nurse, maybe a second-year nurse, you're just trying to get the patient to that goal of cardiac output. But as you move forward in your career and in your extensive expansion of critical thought, you can never look at these numbers in isolation. You have to always look at them in relationship to whether or not tissues are well oxygenated and whether or not you have adequate oxygen delivery. That is so incredibly important, and it really drives us in terms of what we do in our care. Just want to remind anyone who's joined, Zoom doesn't automatically mute you, or I haven't figured out how to do that, so please mute yourself. Thank you so much. Okay, so we always remember those trio of major factors which affect ventricular efficiency and ventricular output. So heart rate, of course, heart rate times stroke volume. Heart rate is what we see. Heart rate is frequently what we treat. And we're going to pay a lot of attention to an increased heart rate. Stroke volume is really what you care about. So if you have a preload deficit, preload in this case meaning volume deficit, always important to remember that actual preload is about the dynamic stretch of the myofibrils right before ejection, which is pre. So volume into the ventricle, stretch, 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 stretch. That's your preload pressure. That volume in the stretched ventricle. The less stretchy the ventricle, the less compliant, the higher the pressure will be, even though the volume might be low. So we always look at this with a jaded eye to say, if I give you a liter of volume and your preload pressure, either CVP, PAD, or wedge, your preload pressures go up aggressively, your ventricle's not compliant. Period, end of discussion. I can't give a normal healthy heart a liter of volume and see that CVP increases. So when I'm giving you volume and CVP increases aggressively, I already know you have a non-compliant ventricle. Afterload, we treat with vasoactive therapy. We either vasoconstrict or we vasodilate. But really, really important to understand that afterload is actually about the degree of tension or work that the ventricle must generate to move blood out into the artery. Now, we measure afterload in the artery. We talk about it as systemic vascular resistance or peripheral vascular resistance for left ventricular afterload, and pulmonary resistance for right ventricular afterload. The more resistant the artery, the harder the heart has to work. The more resistant the artery, the more the stroke volume goes down. The more resistant the artery, the more stroke volume goes down, the more the heart rate goes up. So you may actually see, as you're using a vasopressor, that the cardiac ejection or the cardiac output doesn't change, but the efficiency of the cardiac output, which is the stroke volume, has gone down. That's so incredibly important. And then ultimately, we're looking at the inherent contractile property of the myocardium. So both volume load and compliance, resistance load and work actually affect the contractile property of the myocardium. And that's an intrinsic strength of the cardiac muscles. Really, really important that that intrinsic strength is evaluated and that we appreciate that inotropic support may be needed to move the volume load against the resistance load. And when we see that volume load is going up, in other words, venous pressure is up, volume extravasation has increased, but arterial volume is going down, before we add a vasoconstrictor, we should actually consider, I'm not saying it's always going to be the right answer, but we should actually consider the utilization of inotropes. Now, really giving a patient inotrope, you must have a way, I mean, I think it's essential in all critical patients, but particularly here, you must have a way to look at stroke volume. As I give you an inotrope, I expect your stroke volume to go up. That means you become more efficient. So I'm really going to look at contractility and stroke volume as a simultaneous measurement. If I need to increase your contractile function, I gave you volume, your stroke volume didn't increase. I started you on vasopressors, your stroke volume decreased. I'm going to give you an inotrope to see if I can improve your stroke volume, and that's going to be really important. Now, that lends itself to understanding why it is that we really need to have a methodology to look at cardiac output and probably more realistically, stroke volume. So we have both right-sided, that's the PA catheter, and left-sided measures. What we talked about last week, which would be non-invasive and minimally invasive, using thoracic bioimpedance, using FlowTrack, using ClearSight, using perfusion index, using pulse ox, using systolic pressure. Those are all left-sided measures. Today, we're going to talk about right-sided measures. And in a healthy heart, right cardiac output generally trends with left cardiac output. But once the heart becomes unhealthy, if you have a pulmonary embolism, if you have hypoxia, if you have chronic pulmonary hypertension, that's a no-brainer. Or if you are using PEEPs greater than 10 centimeters of water pressure, that you're going to cause a dissociation between the right heart and the left heart. And now it becomes even more important for you to consider the measurement of right-sided cardiac output using a PA catheter, left-sided cardiac output. And by the way, sorry to tell you, all of you out there, especially if I have some nurses from the CVICU at Grady Hospital, the best validation of your cardiac output, and there's really two, I'm only talking about one today, is actually a fit calculation. Oh my God, we all hate doing a fit calculation. We always feel like it's such a pain, but it's a really great evaluative tool to tell me about cardiac output. The other thing that you can use, I'm not talking about it today, but I'm just going to mention it. Some of you have been with me. Some people on this call are with me every single day, every single week. Others have been here a lot. I just want to remind you that the venous CO2 minus the arterial CO2, so central venous CO2 minus arterial CO2, also is an excellent indicator of cardiac output. Hi, if you've just joined, please mute yourself, my friend. All right, if I can do it, I did it. Okay, good. All right, very good. And the reason you mute yourself is because you might be having a private conversation, plus it causes a lot of echo. So thank you so much for cooperating. All right, my friends. So our goal is to optimize blood flow dynamic. And that's always going to be your goal, no matter what it is you're doing. You give them fluid, you give them vasopressor, you give them an inotrope, you give them vasodilator. You're just evaluating the patient at the bedside. You always want to be sure that you are evaluating true cardiac output. So remember, the first kind of cardiac output we talk about and what we think about overall is your systolic blood pressure, your MAP, your stroke volume, either thoracic or peripheral stroke volumes. And that's a beautiful left heart measure. Don't ever lose that. Always consider it. It's really important also to have a comparative analysis. But what we want to think about is really how are we going to maximize the essence of your stroke volume? So, of course, one of the things we'll do is we'll give you volume. And if you've got a nice stretchy ventricle, that volume will convert to an increased stroke volume. If I apply a vasopressor, because you're hypotensive, that is immediately going to cause a decrease in stroke volume. So you've got to stand there at the bedside and say, do I want to continue titrating upwards on this vasopressor when I am seeing evidence of a decreased stroke volume? I might not even be measuring the stroke volume or cardiac output, but your urine output is going down. You're gaining weight. Your base deficit is getting worse and worse. You got to be able to tie that back to your vasopressor and think about whether that is the right therapeutic intervention. And then, of course, adding inotropy. And as you add in inotropy, you actually are going to, you hope to see an increase in stroke volume. And remember, that's a really important part of your cardiac output. Now, this is why we give volume, but we give volume a lot of times really indiscriminately without measurements and without endpoints. It's also important to remember that clinical signs come in. So people say to me, I don't need to measure cardiac output. I can just hold my patient's hand and feet. I can look at capillary refill. I can look at their mental status. I can look at urine output. I know what's going on. I love that. I love a good clinical assessment. It's so valuable. But these things actually correlate rather poorly. By the time you start to see these really aggressively change enough that you're seeing them, you have a significant reduction in blood flow dynamic, a significant disruption in metabolism at the cellular level, a significant increase in production of metabolic acid, and you've sort of already missed your opportunity to resuscitate the patient before there was cellular and organ dysfunction. So we really have to pay more attention to that. So now that's just kind of a review of what we talked about last week. Now let's talk about our invasive cardiac output. So invasive cardiac output will include thermal dilution by bolus, thermal dilution by heat pulse, which we call continuous cardiac output, and Fick methodology. These all require a PA catheter. So this is the most invasive form of hemodynamic monitoring we do. Okay, and I just want to remind you, cardiac output is the volume of blood ejected by each ventricle per minute. Right and left are not equal. Right-sided ejection fraction is 40 to 60% in a good heart. In a good heart, left-sided ejection fraction is 50 to 75%. And very important to remember that right and left ventricles share a sac, that's the pericardial sac. They share a wall, that's the septum, and they share circulations, right to left, pulmonary circulation, left to right, systemic circulation. So it's really important to kind of approach the bedside appreciating that right doesn't necessarily equal left, and that there can be very significant dysfunctions on one side or the other, or both, and not to always come to a bedside with a bias. It's all left heart failure, it's all right heart failure. It's never all of anything. It always, though, requires that you have a good clinical eye. So what does a PA catheter tell us overall? So if we're using an advanced PA catheter, that's one that has continuous SpO2, you get CVP. And how I've listed this here is in blue, these are deoxygenated side measures. So they're basic right heart measures. CVP, PA systole and diastole, those are right heart measures, and they're deoxygenated blood measures. SpO2, which is a mixed venous, meaning all the veins have mixed together, not that you've mixed arterial and venous, mixed vein blood all together, and cardiac output measured with the PA catheter. These are all blue. The only thing that really is a good reflection of left ventricular function from a PA catheter, and it's variable, it depends on how much positive pressure you're on, where your catheter is placed, but in the best situation, when you inflate the balloon on the tip of the PA catheter, you get a wedge pressure. And that wedge pressure, out of everything I can measure with a PA catheter, it is only the wedge pressure, which is actually LV reflective, and it's very indirect. So why not call it what it is? This is a right heart catheter. That's what they call it in the cath lab. That's what Swan and Gans called it. They said it's a right heart catheter. But they were in a day when pretty much right heart and left heart were equal, relatively equal in function. They never looked at right ventricular infarction, and they also didn't have positive pressure breathing to alter the relationship between the right heart and the left heart. Now, we have a lot of calculated data. We have stroke volume, that's calculated. Cardiac output, that's calculated. Vascular resistance, that's calculated. Oxygen delivery, that's calculated. And we have extended calculations, especially with advanced PA catheters. We can look at stroke work and stroke work index. We can look right ventricular and diastolic volume and right ventricular ejection fraction. So here's the thing, if you're going to put in a PA catheter, get every bang for your buck, use the most advanced catheter. We currently at Grady offer two catheters. We offer the most advanced and we offer the least advanced. The most advanced for medical ICU, the most advanced for surgical ICU, the most advanced for trauma patients, the most advanced for CV surgical patients, but our interventional cardiologist doesn't like the most advanced, so he uses the most basic PA catheter. Okay, so I'm going to look at a comparative analysis of those two catheters, just very basically. This is a basic catheter. The basic catheter has an infusion port, the PA distal, the balloon port, the proximal injectate port. I hate those terms. This is the RA lumen. This is the PA lumen. This is the air lumen. This is your infusion port. And then you have a temperature measure that's called your thermistor. So you have one electrical, one air, two continuous pressure connected to pressure tubing, continuous pressure lumens, and one lumen that allows you to give aggressive resuscitation of any agent you like, because it's going to mix in the RA where there's a really big blood pool mix, so you can use extravasating medications through here and everything else. Remember, only air through here, and this is going to connect to a thermistor probe that's going to actually tell us continuously what our patient's temperature is, and it's also going to show us temperature change when we inject a bolus here. This is an advanced PA catheter, and you know that because you have a blue card. That blue card is an oximetry card. It plugs into a basic cable that actually reads continuously SpO2, which is mixed venous saturation. Two thermometer connections, and I'll show you why in just a minute. Proximal injectate port, RA infusion port, PA distal port, and your air port, the balloon inflation port. When I inflate that, this is the only catheter ever made, ever known to man, probably the only one you'll ever have, which is when you inflate the balloon, the catheter sails forward into an occlusion position, and in occlusion position, the distal tip is looking at the capillaries, the venules, the veins, the LA, and ultimately the LV. It's so gorgeous just by inflating that balloon. When you deflate the balloon, the catheter comes back. Okay. So unfortunately, I don't have cardiac output here. I'm so sorry. This is just the visualization of my PA pressure. Here's a visualization of my central venous pressure that's being monitored from my PA catheter. It's actually not CVP. It's actually RA pressure, but okay, just call it CVP. That's fine. Okay, so now we just think about our basic bolus thermal dilution pulmonary artery catheter. So the temperature of the blood is determined by the thermal dilution. Now that word means I'm diluting the temperature, and I'm diluting the temperature by injecting a cooled infusate, a certain volume, and that certain volume of cool infusate changes the temperature of the blood in the right ventricle. How quickly the temperature comes back to normal is what is used as the calculation of cardiac output. So for the majority of us in today's world, lots of us aren't doing this anymore. We may or may not be using PA catheters, but probably for those folks who use PA catheters, they're using an advanced one, but that's okay. It's really important to talk about this as well. So at our bedsides, we use D5W because the rate of speed of the D5W molecules is what is propagated in the algorithm of the PA catheter. So we'll give you a bolus of 10 cc's of D5W that is injected very rapidly in the blue lumen, the PA injection port, or RA injection port, proximal injection port. You're going to inject that 10 cc's of volume through that blue hub, and you're going to do it really fast. You got to do it in less than 2 seconds. You do it really, really fast, and you do it during exhalation. That dilutes the temperature of the patient's warm blood, and as that returns back to normal, you're measuring temperature change over time and plotting it on a graph. Now, lots of things can interrupt that reading, and that's really important for us to appreciate. Things we can't control, right? Tricuspid regurgitation. Well, that makes sense. You're not moving the cool volume through the system. You're regurgitating it back into the right atria. Intracardiac shunt, right to left to right, is going to affect the dilution of blood and the dilution of temperature. Cardiac dysrhythmias, which just affect the contractile property of the heart. And a really important one that we don't think about very much, and that is the introduction of positive pressure ventilation. Every time you get a positive pressure breath, you compress the pulmonary vessels, and that basically causes a minor stasis of volume in the right side of the heart, and that changes the plot over time of temperature change over time. So in thermal dilution, all you're using is cool injectate, and that temperature is the indicator of how well the blood is flowing through from the right ventricle into the pulmonary artery. And it is widely used in centers around the world, but more commonly today is going to be the continuous PA catheter, continuous CCO, continuous cardiac output CCO, and continuous SVO2. So again, in either case, it requires an insertion of a PA catheter, also known as the Swan-Ganz catheter. And you actually have to have very good timing and a lot of strength, and you've got to inject that bolus, the D5W, into the right atria, changing the temperature of that warm blood, making it cooler, even with room temperature injectate. And then that plot of how long it takes that temperature to come back to normal is then calculated in the cardiac output. So of course, if you're doing a cardiac output by intermittent thermal dilution, even though you may have evaluated where the PA catheter was when you first placed it, you always want to be sure that you are in good placement, that the catheter tip is in the PA, that the RA port is in the RA, the proximal injectate port is in the RA. Really need to be sure that catheter is placed well. And if you're using older methodologies or older monitors, you actually have to put in the make and size of the catheter, the volume and temperature of the injectate, and you're using basically a closed syringe and inside inline syringe. But if you have newer devices, so for us, we'll call that the hemisphere, that's an Edwards produced tool. And with the Edwards produced tool, when we do an intermittent cardiac output, there's recognition when you connect to your catheter of what the catheter size and diameter is. And it actually promotes what we call the calibration constant, or the calibration constant, which actually calibrates how much fluid is in the catheter itself. So that's factored in making a decision about how quickly the temperature of the blood return to normal. So very important to know that you've got to look at your patient's blood temperature and the injectate temperature, and the difference between these has to be at least 5 degrees. So if your blood temperature is low, you're in TTM, and your injectate temperature is room temperature, not going to be enough of a difference for me to measure your cardiac output. You've got to have a difference of at least 5 degrees. And you really want your patient to be supine, if possible, when you make this measure. It's going to be a much more valid measure, but never greater than 20 degrees elevation. So the higher up the patient, the less valid any measurement that you make is going to be. So this is just a lovely little video from Edwards. You can download it from Edwards Life Science if you're trying to teach people or help them understand. It's a fantastic video. You just go to Edwards Life Sciences Critical Care, download the video. So this is intermittent cardiac output. Here is my proximal injectate. I'm pushing in 10 cc's of fluid into the RA, change the temperature in the RV, and the temperature change is measured at the tip. Now, the catheter you're seeing here is an advanced catheter because they could only afford to make one video, but it's a thermal dilution by injectate. So I just want to look at that again. I'm going to bring that here so that you see as we inject that fluid into the proximal injectate port, it actually is distributed in the RV, and then that blood carries it up into the pulmonary artery, and you get a waveform analysis that's, even though you're making the temperature of the blood cooler, it's not an upside down curve, it's an upright curve. Peak temperature change and return to normal. Okay, so let's just take a look now at something that's static. A normal cardiac output, which is just like what we just saw. I bolused you during expiration. I did it in 2 seconds, 10 cc's, room temperature injectate, and an appropriate, what we call calibration constant, okay, or computation constant. Here's your normal cardiac output. If your patient has a high cardiac output, they'll rush up to the peak and rush down to the bottom. Up to the peak and down to the bottom. Usually you won't have that little noise there, just up and down. So it goes up much faster, returns much faster. See how you have that delay over time? The lower cardiac output takes a longer time to reach its peak and a much longer time to return to normal. So by just looking at the cardiac output curve, you can get a feel for what's actually occurring. You can't really see it when it's all compressed in this window, which is a problem. You really want to look at the curve itself at the time that you're injecting. Once you look at things in comparison, all that data gets compressed. Okay, now here you can see that the injection technique is improper, not just because of the slow rate of rise, but you never really reach a peak. You kind of have that dip here. This is really an improper injection technique. So really important to appreciate. You can do this on your bedside monitor. You can use the hemisphere. And what you're going to do, typically what we do is we do 3 injections about 1 minute apart. And we take the 2 that are within 0.05 of each other. None of them are really within 0.05 of each other. And we average those 2 together, or the monitor averages those 2 together to give us an average cardiac output. They're all similar in value and appearance. They're all pretty close to each other, but you do have a deviation of 0.4, and that's pretty significant. Okay. Continuous cardiac output, newer generation, really fantastic, quite fabulous. And with newer generation catheters, we are using a continuous cardiac output measure that's actually propagated by pulsing heat. And a more advanced PA catheter provides for continuous SpO2, which gathers more information for you. And you can also look at right heart volumetric data. Now, remember, this is a right heart catheter, so the more information I can get about the right heart, actually, the better off the patient is. Okay, so guess what? T is still determined by thermal dilution, but before we use cool fluid as our indicator, now we're going to pulse heat into the blood, and that's going to be done by a thermal filament on the PA catheter. And that thermal filament actually transitions from the right atria into the right ventricle with a small amount in the pulmonary artery. And that thermal filament is going to pulse heat every 5 to 10 seconds, changing the blood temperature. And what we're going to see is how quickly or slowly the blood temperature returns to normal is going to be actually evaluated as in an algorithm as cardiac output. And the same kind of things affected here. The difference between continuous cardiac output monitoring thermal dilution is that it's heat and it's not user affected. Bolus cardiac output is using cool fluid, just room temperature fluid, which is also very affected by the user who's operating the methodology, how quickly they pushed it. Did they push it at the right time? Did they hold the barrel of the syringe in their hand and make the injectate warmer? So there's a lot of variables that affect bolus thermal dilution that are not nearly as important in continuous thermal dilution. So now let's take a look at the continuous cardiac output. And again, it's going to be downloaded from Edwards Life Science. Such a nice video, free for you to use, probably was $100,000 video. You can use it for free. You can download it and put it in all of your slides. Okay, so now we're going to look, same PA catheter, but now what we're going to use is the thermal filament. And that thermal filament pulses heat, and it changes the temperature of the blood. So by changing the temperature of the blood, that warmer blood goes up into the PA, and what we're looking at is how soon the temperature returns to normal. So again, you have this basic cardiac output curve. You're not going to see it because it's happening really frequently, right? Every time we have a heat pulse, we're going to see a temperature change. So sometimes when there's a delay, you can see you have a longer heat pulse, and these are all different measures, because every time the ventricle ejects, you're going to have a different stroke volume. It's going to average those stroke volumes together over a 20-second or 60-second time period. You get to choose that on your monitor, 20-second time period or 60-second time period, and it's going to propagate your continuous cardiac output. So again, remember, this is a right heart measure. It's about temperature change over time. So please appreciate what I've said to you. This is not a direct measure. It is an indirect measure that looks at temperature change over time, either because I bolus the patient with fluid into the proximal injectate port, or because I'm utilizing heat pulse technology, but it's looking at temperature change over time. Now, I want to make sure you appreciate what I've said to you, because I think this is critically important. The temperature change over time is affected by how much volume you are mixing the indicator in. So the indicator is the cool fluid, the indicator is the heat pulse. But if I have an engorged right ventricle that has a lot of volume, that's going to actually be predictive of a high cardiac output, which indeed it's not. There's not a high cardiac output, but because you have a high degree of volume, you're going to get an indicated high cardiac output. And you're going to say, if you did a PA cardiac output and the cardiac output was 14, but your patient was profoundly hypotensive and they didn't have any blood flow to the peripheral digits, you'd say, something's wrong with that equipment. Oh, no, no, no. No, no, no. Nothing's wrong with the equipment. You've got to figure out how to get that blood from the right ventricle to the left ventricle. That's really the importance here. And by the way, in the next version of the hemisphere, which is what I use, I will be able to do a comparative analysis of my systemic arterial cardiac output to my pulmonary arterial cardiac output. That totally will facilitate for me what kind of treatment profile that patient is going to need. Because if the PA cardiac output is high and the LV cardiac output is low, what I'm going to do is open up the pulmonary vault and support the right ventricle ejection. So what I really want in the end is that my PA data comes down, my left ventricular systemic arterial data goes up, and they become relatively equal. Then I have actually treated my patient effectively. Part of the reason PA catheters have been pooled is because A, we didn't understand how to use them. B, we were infarcting people's PAs because catheters were stuck in wedge. C, nobody was really looking at waveform analysis. And D, nurses were gathering all sorts of data and nobody paid any attention. So, you know, we kind of lost the ability to have this incredibly profound right heart evaluative tool. Now, don't let that happen to you if you're using FlowTrack, ClearSight, Starling. Like, you gather that data and your docs aren't listening, they don't care, and they say, go away, you're bothering me, kid. You got to change the way you communicate. Got to say, your patient's stroke volume is down and their tissue acidosis is up. What are we going to do to improve stroke volume? Don't talk to them about the brand name of what you're using. They don't care about that. You tell them that if they ask you, but that's not how you start a conversation. Doctor, Mr. Smith's stroke, I have had to increase his vasopressor, and as I did, his stroke volume decreased. So now I'm concerned that he has tissue hypoperfusion. And by the way, his level of metabolic acidosis, his base deficit, his bicarb, his anion gap, those have all gotten worse, doctor. So what are we going to do to improve stroke volume? Okay, so probably 50% of your physicians are going to say, oh, thank you for that great information. Here, let's try this. Another 25% are going to say, where'd you go to medical school? And another 25% are going to say, what conference did you attend? Okay, well, you know, demeaning comments. I'm respecting you as a physician. You respect me as a nurse. We're both taking care of the patient, and I'm trying to do what's right. So I am making a commitment right now in my everyday practice to actually observe scientific information and present it scientifically, not emotionally. Don't get your feelings hurt. You're trying to overcome a big thing, and that's culture. You're trying to overcome a long history of nursing subservience. You're trying to overcome what historically was female oppression, and you're doing that all with science. And isn't that an incredible experience? Now that brings us here finally to FIC. And here I'm going to talk about FIC in the opposite way, because I have physicians who love FIC and nurses who hate it. And they say, why do I have to do a FIC? What's the meaning of FIC? Why does that cardiologist always want me to do a FIC? There's a reason. Okay. Now, so first and foremost, FIC was described in 1870. Okay, this is really old. And basically, FIC is a calculation that looks at the content of arterial hemoglobin and the content of mixed venous hemoglobin. So content is arterial sat times hemoglobin times 13.6, but not times 10. Okay, I think I put that in. Let me get rid of that. That's terrible that I said. Oh, whatever. Okay, so arterial sat SaO2 times hemoglobin times 13.6. You only add in the 10 if it's 1.36. Arterial sat times hemoglobin times 13.6. And then you subtract mixed venous saturation times hemoglobin times 13.6. That's called content of arterial sat minus the content of venous sat. And it requires that you have a mixed venous blood gas, not a central venous blood gas. Okay, so we're going to assume oxygen consumption, and we're going to divide that by CaO2 minus CvO2. So I'm going to talk about that a little bit more. Okay, So Fick basically said cardiac output could be determined by concentration of a substance in the blood. Well, people use that. They use that with indicator injection of cool fluid. They use it with indicator injection of lithium. We use a lot of different indicators to actually evaluate this, but this is your patient's own indicator. That's oxygen. SaO2 minus SvO2, CaO2 minus CvO2. So really, really important when we take a look at that. Requires that you have mixed venous saturation. That's the most important thing. Got to have mixed venous saturation. Okay. And what's really important to remember about mixed venous saturation is this is the oxygen that remains available in the blood after you have passed blood past the cells. If the cells are using a lot of oxygen, SvO2 goes down. If the cells are using less oxygen, SvO2 goes up. That's really pretty simple. And so we're going to use that information, SaO2 minus SvO2, or we're going to do a calculation, SaO2 times hemoglobin times 13.6, SvO2 times hemoglobin times 13.6. If you're doing a Fick calculation, you have a model, somebody has written it out for you, you wrote it out for yourself, it's available, and you're doing it at the bedside. But what's really important is what you're actually looking at is the change between oxygen that goes out and oxygen that returns. Okay, so let's look at this cartoon. Again, those who've been with me a lot see this cartoon all the time. This cartoon is everywhere. I use it all the time. Saturation of your hemoglobin occurs in the alveolus. That saturated hemoglobin is saturated with oxygen, returns the left atria, the left ventricle, and is ejected out into the systemic artery. And you're oxygen richer. That's what your SaO2 is representing. As that blood moves through the capillary, the cells use the oxygen. That causes deoxygenation of the hemoglobin. The role of the hemoglobin is to release oxygen, to dissolve it in the blood so it can be used by the cell. So as my SvO2 drops, it means I'm using more oxygen at the cell. That always, always, always means, even if the problem is the tissues are hypermetabolic, it just always means you don't have a good enough cardiac output to maintain delivery of oxygen. That's so important. A low SvO2 means that my cells are demanding a lot of oxygen and I cannot compensate by increasing arterial delivery. So I've gone into that secondary stage to remove oxygen from my venous reservoir. Oh my God, remove oxygen from my venous reservoir in order to provide appropriate oxygenated blood flow. Okay, so now that blood leaves the capillaries, mixes in the central vein to the RA, mixes in the RA to the RV, and the last mixture that occurs here is from the coronary sinus and is ejected up into the pulmonary artery. Now, remember, I'm saying to you, you can't really use CvO2. We're just going to use SvO2. Well, CvO2 is central venous. We're going to use SvO2. SvO2 is the mixture of all venous blood. So I'm measuring that desaturation of hemoglobin as a global indicator of what the cells were doing. And anytime your SvO2 mixed venous is less than 60%, it always means you couldn't compensate with an increased cardiac output. Get thee to the cardiac output and do what you can to raise that up and really focus on your stroke volume. Give volume, give inotrope. Be aware that vasopressors may make things worse and they may make measures abnormal. Okay, so I love that SvO2. So SaO2 minus SvO2, basic principle is what's used in Fick. Okay, well, Fick never said keep it simple. He never thought about keeping it simple, but I want to keep it simple. Your blood flows through organs and tissues. These organs and tissues consume oxygen. The venous blood returning from those organs and tissues has less oxygen. That's why the SvO2 is down. The cells have used the oxygen. The difference between arterial and venous oxygen tells us about the adequacy of the oxygen that's being delivered from the left side of the heart, the appropriateness of oxygen being delivered to the cellular level, and that difference in the content is key. So that's why we use Fick. Fick actually, I'm sorry to say it, a good measurement of Fick, which actually the best measurement is with exhaled CO2 and all these other measures looking at biometabolic hearts. The best measurement of Fick is better than bolus thermal dilution or continuous thermal dilution. The thing is, none of us do the best measurement of Fick. we basically just use the substitute, right? We're using a substitute. We're using a marker substance. That marker substance is oxygen, and the easiest organ to look at is, of course, the lungs. But what we're going to say is, even with this kind of indirect evaluation and calculation, we're going to find this to be really fairly valid. So direct Fick method means that we're looking at inspired, expired oxygen difference and the VO2. That's the direct method. But what we're typically going to do is an indirect method, and that's the CaO2 minus the CVO2. So again, CaO2 is the content of oxygen available in the arterial blood. It's saturation times hemoglobin times 13.6. CVO2 is the saturation in the mixed vein times hemoglobin times 13.6. The same formula. The difference is you put in one from the arterial sat and the other from the venous sat. Along with echocardiogram, the Fick principle, it's the gold standard for measuring cardiac output. It's a great measurement device. We're doing it indirectly, so we're making some suppositions and we're accepting certain things, okay? But it still is a fantastic method. So here is the actual calculation. Oxygen consumption, that's the consumption of oxygen over a minute. That's V, should have a dot over it. V dot O2, consumption of oxygen over a minute by all of your cells and organs, divided by Ca minus CvO2. Beautiful, perfect. Okay, so it'd be great if you could measure metabolic rate, but we don't. So basically we use the calculation, and it's going to be the same for everybody. 125 times BSA, normal VO2, 125 times BSA. So your BSA, 2.1 times 125, somewhere around 260. So your oxy consumption is 260, okay? And then you're going to take that oxy consumption, see that's the BSA2, took that standard factor, this is a standard factor, 125 times your BSA. We're going to just use this formula. 125 times your patient's BSA, and that's going to actually predict their oxy consumption. Now, that may not be right because it's a prediction calculation. And then we take that oxygen consumption and we divide that by CaO2 minus CVO2. Normal CaO2 is 17 to 20%. Normal CVO2 is 13 to 17%, 13 to 15%, sorry. So 20% minus 15% is 5. Right, I'm going to divide 250 by 5 and multiply that times 10. That's going to give me a calculated cardiac output. Okay, so I'm going to predict or assume oxy consumption. Prediction or assumption of oxy consumption uses standard factor 125. Multiplied times your BSA, that's your oxy consumption. I'm going to take your SaO2 and your SVO2, and I'm going to multiply each one independently. SaO2 times hemoglobin times 13.6. CVO2 is SVO2 times hemoglobin times 13.6. I'm going to divide that difference, that number, into 250, and I'm going to multiply it times 10. So here you see the numbers 5. 5 into 250 is 5, and 5 times 10 brings me to 5 liters per minute. There's a lot of limitations because it's not a real measure, okay? So we're assuming your oxy consumption. It's estimated by body weight because it's an indirect method rather than calorimetry, which is the real methodology. A very big burden. We're not going to do it. It's too much trouble. But there are some significant errors that occur when you have very small differences in saturations in hemoglobin between measures and absolutes. Okay, so there are problems with the Fick calculation, but overall, most cardiologists will tell you they'd rather have a Fick than a continuous cardiac output or a bolus cardiac output, because in thermal dilution, not only is it not accurate in tricuspid regurgitation, patients who have a low output state will have an overestimated cardiac output. It is a right heart measure, not a left heart measure. When you look at CaO2 minus CVO2, that's a left heart measure. That's a real left heart measure. So Fick gives me a left heart measure that's based on some data that I can get from the PA catheter, which would be my SVO2. Thermal dilution is a right heart measure. It always was, it always will be. So it's really important to appreciate the difference. Thermal dilution is a right heart measure. It's affected by right heart failures. It's affected in low cardiac output state. And if you're doing bolus thermal dilution, it's affected by the person who's making that measure. If they're not injecting quickly, they're not doing it at the right time, didn't correct the calibration constant, the computation constant, those things will give you invalid data. So a lot of cardiologists feel that FIC is more reliable, even though you are just estimating the oxy consumption. But I got a patient with a fever, he's got hyperinflammation, he's consuming more oxygen than what I'm actually calculating. But what I'm calculating is at the upper limit of normal oxy consumption. So all things being equal, it's probably hurts me to say it. Oh, it hurts me to say it. Probably the best methodology overall of really truly evaluating left ventricular cardiac output. Hurts me to say it because I love the PA catheter, but I also know the PA catheter is a right heart catheter. It's not a left heart catheter. But you know, old notions are hard to release. I released them a long time ago, so hopefully you'll release them now too. So now let's just do a really quick device comparison and how we measure stroke volumes and cardiac output. So we talked about Doppler last time. You can use it anywhere. It's pretty easy to use, pretty good accuracy. Don't really know about the reimbursement. Regular Doppler. So really this would be your echocardiogram, not your ultrasound, right? Use it usually in the OR and the ICU. It's excellent use, good accuracy, and pretty good professional reimbursement. Econ, which really is looking at your expired gases, usually use an OR or ICU. It's good, accuracy is fair. Bioimpedance, you can use anywhere. That bioimpedance is like the Starling, or really bioreactance is the Starling. Bioimpedance is a little bit older. Most of us aren't doing that at all. Looking at pulse contour methodology, that would be FlowTrack, LIDCO, PICO, ClearSight, which we talked about last week. We can do that really in the OR, the ICU, or anywhere a patient has an A line. Anywhere a patient has an A line. It's minimally invasive, accuracy is fair, and you have some professional reimbursement. NICO or NICOM is really about expired gases, looking at end-tidal CO2 for measurement, typically only used in the OR and ICU, and really not used much in the United States. It's difficult to use and has fairly good accuracy. So right away, I'm saying, okay, ultrasound, echocardiogram, PA catheter, good for the right heart, bioreactance, good for the right heart. And the other things are kind of fair. So I'm thinking about what's really going to be the best for the patient. And then I want to remind you what nurses can do without a doctor's order, as long as you have a protocol. In my hospital, a nurse who is caring for a patient with an A-line can attach a FlowTrack transducer and monitor stroke volume. A nurse can apply a volumetric pump device. That's what ClearSight is measured. LIDCO requires lithium injectate and a central line, so you need a doctor for that. PICO requires a femoral arterial line and a central line. You need a doc for that. But at my hospital, if you've got an A-line, I can do FlowTrack. And if you don't have an A-line, I can do ClearSight. At my hospital, I can apply bioreactance pads, that's the Starling, and I can evaluate your stroke volume. I don't need a doctor for that. But I do need a doctor who's going to observe the information, utilize the information, act like that information is of value to them, and act on the information that they're receiving. That, of course, is the issue. PA catheter, of course, requires a physician for placement of the PA catheter. So we have to think about what we as nurses can do ourselves with the tools that we have, and what we need our physicians to do. But above everything else, we need buy-in on the importance of stroke volume and on the importance of cardiac output. That's critically and profoundly important, because it's not the tool that you're using, right? It's not the tool. The tool is not therapy, right? The tool is giving you information that you add to your armamentarium to build a case that you have a patient who needs assistance. They might need volume, they might need inotrope, they might need vasoconstriction, they might need vasodilation, they might need all three. We don't actually know until we test their ventricle, and that's always what we want to do. So the two most important clinical indicators, remember, I want to add this in. So I've got a normal SVO2, but I have a rapid respiratory rate and a rapid heart rate. Typically what that means is I never delivered oxygen or blood through the capillaries where the tissues could use it, and I have continuous hypoxia at the cellular level. Sustained tachycardia should always be investigated, and we're going to assume until proven otherwise that a rapid heart rate is compensatory for inadequate stroke volume and therefore inadequate circulatory flow. Measure the stroke volume. Measure the stroke volume. It's compensatory. Now, it might be pain, could be anxiety, could be fever, all of those things which actually increase oxygen utilization. Just assume tachycardia is compensating either for low stroke volume or tissue hypoxia or both. So that's the first thing you look at is the heart rate. Second thing you look at is the respiratory rate. Rapid respiratory rate is probably the most prodromal indicator non-invasively for us to evaluate whether or not you have adequate cardiac output. Rapid respiratory rate is to be assumed to always be compensatory for metabolic acidosis. And we have lots of things that we can check. We can look at your biomedical profile. We're going to look at your total serum CO2. Maybe in your hospital, you call that bicarb, not on the blood gas, on your chemistry. Normal serum CO2, 20 to 28. Anything lower than that means you have high acid. Total serum CO2 or bicarbs down, you got high acid. You have a wide anion gap. You have a wide anion gap greater than 20, you have high acid. And I'm happy to explain the anion gap, it's just not today. Okay, but I've done a lot of talks on it. I'd love to talk about it. I'm happy to do it. On your blood gas at one institution, you might be measuring that bicarb in the arterial blood gas. That number is just a tad bit different than serum CO2. But again, if bicarb is down, metabolic acid is up. If you have a base deficit, that means you are negative in your buffers. That's because buffers are doing their job. They're conjugating with the metabolic acid. Base deficit, low bicarb, low serum CO2, all mean increased acid. Wide anion gap greater than 20, high acid. Really straightforward. Bicarb base, serum CO2 down, high metabolic acid. Anion gap wide, high metabolic acid. Don't be telling me you have no way to measure acidosis. You do. You've done a chemistry, look at the serum CO2 and the anion gap, and in your hospital, they may call that bicarb on the chemistry. And then check your blood gas. In your hospital, you might be looking at bicarb. In our hospital, we look at base deficit. Base deficit, decreased bicarb, decreased serum CO2, wide gap, always means high metabolic acid. These are metabolic acid measures. They don't have anything to do with the respiratory acid. They are metabolic acid measures. When I have a patient with metabolic acidosis, I am laser focused on improving them. If I'm adding vasopressors, increasing the workload to the heart and reducing the blood flow to the tissue, my metabolic acid gets worse. I have done the wrong thing. And if I'm standing at that bedside, titrating up to treat an elusive blood pressure while my patient gets more and more acidotic, while they elicit acute kidney injury and kidney failure, I am participating not in malpractice, not in negligence, but I'm not using all my facilities for thoughtful critical care and critical analysis. That's what I need to do. That's what I've committed to do. So I want to remind you that increasing heart rate and increasing respiratory rate are always a compensatory mechanism, and your responsibility is to evaluate for the possibility of the presence of metabolic acidosis and utilize that information in your communication. Practice it. Okay, the other thing that you can do, again, you're not really doing anything invasive at this point, you're just using critical thinking, is to look at pulse pressure. Pulse pressure is the difference between systole and diastole. Now that's best measured if you have an A-line, but even if you don't have an A-line. A reduced pulse pressure means a reduced stroke volume. So when maybe systole is low and diastole is low, but the difference, which is typically 30 to 40 millimeters mercury, if the difference is 20 or 18, it means you have vasoconstriction, and the probability is you have either hypovolemia or heart failure. When the pulse pressure widens, of course, it could be neurologic, but we're really talking about shocky patients, not neurologically involved, not a head injury or head trauma. So when that widens, systolic pressure is up and diastolic pressure is kind of low. When that widens, what that typically means is you have a very high cardiac activity, a very high stroke volume, a very high cardiac output. And that often is what you see in the very early stages of hyperinflammatory shock where you have loss in vascular tone. So you get a wide pulse pressure in that early period, and we'll just call it, even though it's not the only one, early period of sepsis, whereas with hypovolemia and heart failure, you get a narrowed pulse pressure and a reduced stroke volume. Thing is, your patient needs you to monitor stroke volume if you're able. If you have bioreactants, you put those pads on. If you have an A-line, you put on a flow track transducer. If you have a clear site capability, you put that on. You do whatever you can to measure patient stroke volume, and that's going to give you cardiac output. So I do love to just remind you about the base. The base is always just a calculation that reflects the utilization of your buffers to neutralize acid. And it is very, 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 very significant. These are transposed. So positive value means positive base, less acid, metabolic alkalosis. Negative value, excess acid, less buffer, and that's metabolic acidosis. Sorry about that. And very, very important for us to consider. It's not affected by CO2. Last but not least is the anion gap. Anion gap takes sodium as the main positive ion and subtracts chloride and bicarb as the main negative ions. And that gap should always be less than 20. In the face of metabolic acidosis, the probability is your gap will be wider than 20. So that actually is a predictor of metabolic acidosis in your critical patients. So I just always say confirming acidosis, wide gap acidosis, low gap alkalosis. Look to your chemistry. Your chemistry gives you a bird's eye view on your stroke volume and your cardiac output. Always ask the big four questions. When you have a low serum CO2, a low bicarb, a base deficit, or a wide anion gap. And there are the basic four questions are, does the patient have ketosis? Is he hyperglycemic and ketotic? Does he have high chloride, which is a buffer, but the problem with chloride is when it binds to hydrogen, it makes hydrochloric acid. So it goes from being a weak acid to being a strong acid. Acute kidney injury, again, look at the chemistry, look at the creatinine, and lactic acidosis. And that's only if the other three are minor or not altered at all. And lactic acidosis, as we know, is not 100% reliable for looking at hypoperfusion. But in this case, we're going to use it for hypoperfusion. Treatments save lives, not monitors. Whatever monitoring you're doing, do it well, understand it, apply it critically, have good thinking, try to evaluate it effectively with critical thought analysis. Put together a platform, a presentation before you communicate to your provider so that you are actually providing them with data where they can make good decisions about what needs to happen next. And today I was in a talk and someone said there was something really wonderful from a physician. His name is Stuart Goldstein. He's a pediatric and nephrology intensivist. And he says every day during rounds when he's meeting with the team, he's a nephrologist, he meets with the team and he says, so what are we going to do about the stroke volume today? How are we going to treat the stroke volume? Instead of saying, don't you think we should? What is the stroke volume? How do we measure it? Just stroke volume is low. How are we going to treat the stroke volume today? How can I help you treat that stroke volume? How can I help you treat that acidosis? What can we do together to improve the outcome for our patient? Treatments save lives, not monitors. Nurses have a huge responsibility. They have so many burdens put upon their shoulders, but a lot of those burdens, like I have to clean the room, I have to empty the trash, those are task burdens. This is a thought burden. This is the burden you wanted when you went to nursing school, which was to apply critical thought analysis to make a difference every day in your patient's life. So I hope this little bit of a tool, along with every other tool that we've had together and we will have together, I hope that this little bit of tool will help to change the way in which you look at these data points for your patients and the way in which you'll present them. Remember that I'm going to end the recording and say goodbye to our viewing audience who looks at this on recording, but I'm asking you if you wish to stay online so that we can have a little discussion or you can ask some questions. So thank you very much for attending today's wonderful Wednesday, Cardiac Output Multiplex Part 2. I'll see you next week, and I'm so appreciative for all your efforts and for the care that you give patients every day. Thank you so much.